Hello and welcome to our webinar series, Next Steps in COVID-19 Response in Long-Term Care and Retirement Homes. In today's webinar, we are pleased to be hosting a discussion on updates to on data that has been presented by CIHI, so the Canadian Institute for Health Information, around data and how we can use data to inform improvement in long-term care. I will be moderating this session from my home office in Ottawa, Ontario. I would like to acknowledge that my home office in Ottawa is on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation. We are pleased to offer today's webinar with French simultaneous interpretation. If you wish to listen to this session in French, then please select French from the interpretation menu at the bottom of your screen. We invite you to use both official languages when entering your questions and comments in the chat box. And also as a reminder, this session will be recorded and a summary will be made available to review or share with your colleagues who have missed it. The LTC Plus program and webinar series are based on the Reimagining Care for Older Adults report that was published in July 2020. The report focused on promising practices in 6 key areas that have the potential to reduce the risk of future COVID-19 outbreaks or mitigate their effects. And as always, we are pleased to offer this program in partnership with BC Patient Safety Quality Council, New Brunswick Association of Nursing Homes, CADITH, and CMA Foundation. Before we dive into the webinar series content, we have a few announcements to make. We want to let everyone know that Statistics Canada, in collaboration with Health Canada, the Public Health Agency of Canada, and Canadian Institute for Health Information, will be conducting the Nursing and Residential Care Facility Survey from January 4th to March 31st. Therefore, if you want to respond to the survey, there's still a few weeks left. This survey will allow Statistics Canada to collect comparable data on nursing and residential care facilities in Canada, and will also help them to better understand the extent to which care facilities have been affected by the pandemic, including staffing, standards of care, and gaps in skills and training. So for more information, please go to their web address shown in English and French, and we will also add the web address for easy access into the chat box. Our second announcement is that today is our last webinar in this series, and we will be launching a new series in May. As the LTC Plus program comes to an end and transitions into a phase of new opportunities to support long-term care teams, we are excited to offer this new series, which will focus on broad topics related to care for older adults. Our first webinar in the series will be May 16th, 2022. All are welcome to register for this new series through the link that will be provided in the chat. So now it is my pleasure to introduce our speakers for today's webinar. Philippe Poitras joined CIHI in 2009 as Manager of Specialized Care Data Management. He is responsible for leading CIHI's data management activities in the health services area of rehabilitation, mental health and addictions, continuing care, and home care. In past years, he contributed to CIHI's integrated e-reporting project, helped establish the Master Data Governance Office, and worked with Health Human Resources Data. Prior to joining CIHI, Philippe worked in orthopedic research. He holds a Master's of Applied Science in Biomedical Engineering. We also have Mary Boutet today presenting. Mary Boutet is the Chief Operating Officer at the Pearly and Rideau Veterans Health Center, a seniors care organization with 450 long-term care beds, 139 seniors apartments, and a variety of services across the care continuum. The Pearly Rideau has a special focus on care and services for veterans. Over the past 20 years, Mary has held numerous leadership roles across the healthcare sector, focused on the development and execution of strategy, operational excellence, and quality improvement. She is a Lean Green Belt and is a graduate of the first cohort of the IDEAS Advanced Training Program in Quality Improvement, sponsored by the Ministry of Health and Long-Term Care in Ontario. So welcome to you both, and over to you, Philippe.
Bonjour à tous. Thank you, Tanya, for the introduction and for the invitation to come talk to this group about CIHI's long-term care data. Next slide, please. I want to begin by acknowledging that I'm speaking to you today from the traditional and unceded territory of the Algonquin Anishinaabe Nation. I recognize that this land is now the home of many diverse First Nations, Inuit, and Métis people. Next slide. Our main objective today is to share with you information on CIHI's data collection in long-term care, as well as our reporting. Following the reporting section, Mary will speak about her experience in her facility using CIHI's data to improve quality of care. We'll also touch on some of our COVID-19 resources that we've produced at CIHI that spans really the continuum of care, but I'll focus on those that are relevant to long-term care. And finally, as we all know, COVID has impacted our healthcare system and showed some gaps, but I would say it also has highlighted gaps in data. And so I'll finish with sort of speaking to the priorities for the collection of long-term care data moving forward. We were planning for about a 30 to 40-minute presentation, so there should be ample time at the end for questions and discussion. Next slide, please. Before delving into the data, I thought it'd be good to sort of give a quick intro on CIHI. We're a not-for-profit independent organization that provides information on Canada's health systems. We are funded by Health Canada and through agreements with provinces and territories. Next. At CIHI, what drives us every day is our firm belief that better data informs better decisions, which leads to healthier Canadians. In my mind, and with my engineering background, that data is that critical feedback loop that tells us how we're doing, the areas where we're doing well, and the areas where we can, we may want to focus on improving. We accomplish this vision by delivering pan-Canadian, comparable, and actionable information. And I hope through the examples that I'll show today can show how we've used long-term care data to improve the quality of care in long-term care. Next. As I'm sure you're all aware, CIHI is not the only organization that collects data on health. And particularly during the pandemic, I've been asked quite a few times what CIHI's mandate is vis-a-vis other pan-Canadian organizations. So at a very high level, I just thought I'd share this information to situate how these three organizations work together to provide a comprehensive picture of health and the health system. So Statistics Canada really are focused on collecting data and reporting on population health through surveys and census and things like obesity rates and smoking rates and many more. PHAC is really about monitoring infectious disease. And so during COVID, PHAC provided and was collecting data on COVID cases at the pan-Canadian level. Us at CIHI, we focus our data collection on health services. So services in the hospital or long-term care, home care, and many sectors. Now, although it's a gap in other sectors, just want to clarify that in long-term care, CIHI does collect data from private providers. We do collect data from private long-term care homes, whether it be for profit or not for profit. What we do not collect in long-term care is data on privately funded long-term care, such as in retirement homes or assisted living. Next. Just to give you a sense of the breadth of the data that we collect at CIHI, we manage 28 data holdings that spans more than 10 billion records, and we collect data across the continuum of care and different types of data, whether it be clinical or administrative data, patient-reported outcomes and patient-reported experience measures, PREMs and PROMs, financial data, and health workforce data. As it pertains to long-term care, there's quite a few databases here that can help us understand the long-term care sector. First and foremost, of course, is our long-term care database that we will dive into the next slides into a little bit more detail. In addition, home care helps us because it's often a precursor to long-term care. Hospital database as well, as we can link long-term care residents to hospitals to get an understanding of when they're being transferred to hospitals for more acute care. We also collect financial data in long-term care, and we also have health workforce data. Given the importance of health workforce in the long-term care sector in particular, I thought I'd take a bit of a deeper dive in health workforce as well. My team manages the clinical databases. Another team at CIHI manages the health workforce, but I do want to touch on both today because I think they're very important moving forward. Next slide, please. So CIHI's long-term care database is based on the INTERI assessment. INTERI is an international organization of clinicians and researchers from 30 plus countries, and they've developed this assessments based on evidence. In long-term care, the assessment has over 300, collects data on over 300 items on the individual, things from physical functioning to cognitive and mental health, quality of life items, clinical management, whether it be the health conditions, infections, et cetera, or services, including medications, procedures, et cetera. Now that assessment is, for long-term care data, is completed typically on a quarterly basis for every resident, and that data is submitted to CIHI. Now we use the INTERI assessment at CIHI to collect data on home care, long-term care, and inpatient mental health. Next slide, please. This visual shows us sort of how we use the inputs to produce outputs for decision-making at multiple levels. So as I mentioned in the prior slide, we get the clinical information from the INTERI assessment. We also collect demographic data about the residents, as well as administrative data, including admissions, discharges, transfers, et cetera. And we also have treatment and service data. And that data that we collect on a quarterly basis, we use to produce, I'd say, 4 groupings of different outputs. The first are clinical assessment protocols, or CAPS, like we like to call, and these are really used at the point of care within the facility. CAPS can help identify areas where care can be focused, and it also helps with the care planning. Outcome scales are the second grouping, and they really give an idea of the level of severity of an issue. Things like pain, depression, aggressive behavior, pressure ulcers. Now, outcome scales can be used at the point of care for clinical planning, care planning as well, but they can also be aggregated to understand the needs of a resident group within a facility. The third output are outcome scales, quality indicators. Now, quality indicators, we have 2 types. We have the risk-adjusted quality indicators and the unadjusted quality indicators. In the reporting section, we're going to focus on the risk-adjusted quality indicators. Those indicators are used to compare facilities, regions, and provinces across the country. And we do the risk adjustment so that we can adjust for different resident characteristics that are independent of the quality of care. The unadjusted quality indicator is often used within a facility over time. So when facilities are doing quality improvement initiatives, they can track their progress over time with the unadjusted quality indicator. The fourth grouping is case mix systems. And in a nutshell, what that is it's the ability to group a particular resident based on their clinical profile in what we call resource utilization groups. And in our long-term care, we have 44, and we understand based on staff measurement studies the resource intensity of those different groupings. So case mix systems are used both to understand the complexity of the resident mix in a facility, and you can compare yourself to others, but it's also used in particular in Ontario, and other jurisdictions are also exploring this to create funding formulas and fund long-term care facilities. Next slide, please. All right. This slide speaks to the pan-Canadian coverage of our data in what we like to call CCRS and IRIS. At CIHI, we like acronyms. I'm going to try my best not to use acronyms today, but CCRS stands for Continuing Care Reporting System. It's our legacy database that's based on the RAI MDS data. And IRIS is our integrated INTERI reporting system. It's a brand new system that's based on the new INTERI LTCF data standard. I'll speak more about IRIS at the end in the next steps, but suffice to say that across both systems, this is the coverage we have across Canada of the data. Out of 2,000 or so long-term care facilities in Canada, we receive data from over 1,400 facilities, representing close to 70% of the coverage. Now, it's important to note that for us in CIHI, when we say long-term care and the data we get through CCRS and IRIS, we are talking about publicly funded facilities with 24/7 nursing care. It does not include retirement homes or assisted living. We're also looking forward to receiving data in the near future from Northwest Territories and Nova Scotia, who have started implementing the new Inter-I LTCF standard and who will be submitting to IRIS. Next. As I mentioned earlier, we all know that health human resources has been a big issue in long-term care, particularly highlighted during the pandemic. And so I thought I'd spend a bit of time talking about what data we have at CIHI on health human resources. We typically have supply and distribution data for many professionals, in particular at the record level for nurses, occupational therapists, physiotherapists, and pharmacists, as well as physicians. For physicians, we have very rich data because we receive some of the billing data because of the fee-for-service model, so OHIP data, for example, in Ontario. Outside of these record level data, we also have data for 23 other professions at the aggregate level. Now, we produce statistics on health human resources on an annual basis, and if you're interested in finding out more about the data that we do have at CIHI, you can go to the URL that's listed on this slide. Next, please. As I mentioned earlier, the pandemic has certainly highlighted gaps in our data in long-term care, both for the clinical databases that I'll touch at the end and also health human resources. In particular for health human resources, the ability to have more timely data for capacity planning has come up. The other one is understanding where the professionals, at what facility they are working. In addition to that, understanding hours worked, sick leave, overtime for capacity planning. And of course, given the importance that we all know in the context of long-term care of personal support workers, we don't have data on that, and that has been a key gap during the pandemic. The last piece is really also understanding the different models of care and scopes of practices across jurisdictions so that we can understand how that may impact quality of care. As you'll see in the next slides, we have really rich data and information about the quality of care through the CCRS data, but we don't understand as much the different models, and it would be interesting to see how those models impact care. Next. So moving on now, that was an overview of the data that we do collect at CIHI. Moving on to reporting, our mandate at CIHI is to produce actionable information to help deciders make decisions about the healthcare system and planning. Now, having said that, on this slide here, we do that mandate through both public and private reporting. This slide shows our different channels in public reporting. Let me start with Quick Stats. Quick Stats, we have Quick Stats on our website. If you go on CIHI.ca and search for Quick Stats, you'll find it. We have data across the continuum of care, and in long-term care in particular, based on the CCRS and IRIS data, we produce provincial level aggregate statistics in Excel that you can download. We have, I think it's the last 5 years up live right now of data. It includes everything from administrative data, admissions, discharges, also includes information on the demographics of the residents. We also have outcome scales, and as well as 19 QIs are included in the Quick Stats. So that's one channel. The other channel that we'll spend more time in the coming slides is Your Health System, that I think most of you are probably familiar with. And the final channel is analytical publications, where we do specific analysis on emerging issues and topics, and I'll touch on those during the COVID resource section. Next slide, please. Now, this is your health system, and it's built on our health system performance framework, and it aims to provide sort of the ability to compare performance across facilities, regions, and provinces across the country. We have been publishing at CIHI through your health system the 9 quality indicators that you see listed on the left side for long-term care since 2015. And we think that that has led to some improvements in long-term care. And just to give 2 examples in particular, the use of antipsychotics since 2013, as well as the restraint use, has decreased significantly since publishing these results. Now, of course, this is the result of the provinces and territories putting a lot of effort and time in doing quality improvement initiatives, but at the same time, we think that that data has really driven some of that conversations and is, again, that feedback loop to help continue to improve. In your health system, on the landing page, you can search for any facility or region or province in the country that submits data to long-term care data to CIHI. I just took a screenshot as an example of Baycrest with the falls, and this is what we see when we look at the results. So we see Baycrest's results listed with its regional health authorities result in Ontario, of course. And the way the health system performance framework works is it looks at whether the results are statistically different than the national average. And so if a bubble is in green, it means that the performance is above average. If a bubble is in blue, it means it's below average as compared to Canada. Sorry, if it's blue, it means it's the same as average. And if it's pink, it would mean that it would be below average. Next slide, please. In the next 3 slides, we're going to focus on 3 of those quality indicators, falls, pain, and antipsychotics. Now, we're now looking at falls. This is a direct screenshot from, again, the Your Health System platform. And we see here a trend of 5 years of data. I purposefully didn't include New Brunswick because it only has 1 year of data because they just transitioned to IRIS. As well, Yukon is not included because the relatively small sample size, there can be quite a bit of variation. So it just adds noise to sort of the overall trend that we see here. Manitoba is also not included because we get partial data from Manitoba from WRHA. So what we see here is the falls result. The first observation that we see is that the results do vary across the provinces. That's the first observation. So perhaps an opportunity there to share best practices between some of the provinces. The other thing that I wanted to mention was that the results are relatively stable over time. Now, in particular, that is interesting because the 2020 year, the COVID year, is on this result. Now, what does this result tell us and what does it not tell us? What it tells us is that at a macro level, so at a provincial level, on average, the falls, risk adjusted to the resident characteristics, has not significantly changed between pre-COVID and during COVID. Now, that's not to say that the local experience within a facility could have been impacted by COVID, because the impact of COVID, as we know, hit facilities at different points in time and hit different facilities. And so these results that we see here, the QIs at CIHI, we use what we call a rolling 4-quarter average. What that means is if a resident was in the facility for the full year and received 4 assessments, because they're quarterly, it represents the average of those 4 assessments. So if something particularly happened during 1 or 2 quarters, the results of that may be attenuated here. So the other piece is around data quality. We know that during the first quarter, in particular, extending into the second quarter of 2020, there were some frontline care staff that were redirected to care. And so some of the assessments were paused. Thankfully, and I do want to thank all the long-term care homes as well as staff, the impact wasn't as large as maybe some of us had feared. We're looking at less than 10% data loss in that fiscal year. So Now, having said that, if that 10% is disproportionately towards residents that were more impacted, then that potentially could have a result, an impact on the results. The last piece around data quality is sensitivity and accuracy. Would it be possible that, given everything that was going on in long-term care, that perhaps the quality was affected? We don't know that yet, but it is a possibility. And so the bottom line here is that at a macro level, we don't see a major change in the fall rate, but at the same time, I think understanding the full impact of COVID on the quality of care of residents in long-term care, I think, is going to take some time. Researchers are looking at this data. CIHI is looking at this data, and our understanding is evolving. Next slide, please. This is another example of where we're looking at pain in residents. So the indicator is any resident who had moderate daily pain or horrible excruciating pain at any frequency. So again, we're looking at the risk-adjusted rate over time. Some interesting findings here. In 2016, there was quite a spread amongst all the provinces, and we see that over the last 5 years, both British Columbia and Saskatchewan have shown a steady decrease in the percent of residents that are experiencing pain over these 5 years, and so that in 2020, a lot of the provinces are much closer. The other observation, again, as we saw in the prior slide, is that we don't really see a major change between pre-COVID to COVID. I would say maybe the one that sticks out perhaps is British Columbia, where it was steadily declining and then it saw a very slight increase, but that is very small. All the other provinces is pretty much stable. So we're seeing that pattern, the same as with falls. I would say in your health system, the 9 quality indicators, we're seeing very similar trends. Other than antipsychotic, which I'll show later, there's no obvious change at a macro level, at the province level. I also see that there's some questions coming in. I'll try to address those as they come in. Sorry, I just noticed that. Are all LTC public or private homes in Ontario reporting into your health system? Depending on what you mean by private homes, if it's privately owned, yes. So the not-for-profit and the for-profit homes are submitting to CCRS. Long-term care homes, not retirement homes, but the long-term care public 24/7 nursing, public funded, that is. Now, there are some exclusions where if there aren't sufficiently number of assessments, we will suppress the results in YHS, but by and large, all the publicly funded long-term care homes in Ontario, the results are included in your health system. The second question is, does CCRS combine LTC homes and hospitals with consultative chronic care beds, these two sectors? Yes, great question. I've been focusing this talk on long-term care. I should have mentioned that from the beginning. This does not include complex continuing care. Our quick stats do have data on complex continuing care that we receive from Ontario, and I think we also get some from Manitoba. If you go to our quick stats, you'll notice that the stats are separated, but today's talk is strictly on the long-term care publicly funded facilities. Thanks for those questions. All right, so getting back to this slide, what I was saying is for the most part, what we're seeing is sort of stability through time, except perhaps the antipsychotic indicator where we do see a bit of a blip. Next slide, please. Now, this indicator is looking at the rate, the potentially inappropriate use of antipsychotics. So potentially inappropriate use is basically residents on antipsychotics without a diagnosis of psychosis. As we all know, these drugs are sometimes used to manage behaviors in residents who have dementia, but careful monitoring is needed in those cases because such uses do raise concerns about safety and quality of care. I think, antipsychotics is one example through Healthcare Excellence Canada, who was previously CFHI, and through the AUA collaborative, where many provinces and territories have made significant efforts since, in the last 7 to 10 years to decrease the use of antipsychotics. I don't have a 10-year trend. I wish I could show you. This is a direct screenshot from YHS, but I can tell you that in when we first started reporting this indicator in your health system at a national level, the rate was at about 30% of 2013 data, and it's decreased to 20% pre-COVID. So that's a 1/3 decrease. That's a very significant improvement, and that's a testament to the provinces and Healthcare Excellence Canada and everybody working on that. Now, we also see here Newfoundland has recently underwent a very similar quality improvement initiative, and we see here that they've significantly reduced their rates from 37 or so all the way down to 22, reaching somewhat the national average. So that's a great success story. Now, if you look at this, for the most part, prior to COVID, in the last 4 years, provinces were slightly declining over time, maybe increasing just a bit in Alberta the year prior to COVID, but generally the general trend in the last 10 years has been one of decrease. Now, if you compare 2019 to 2020, there is an increase. Every province and territory except Newfoundland and Labrador, shown here, has increased by at least 1 percentage point in the risk-adjusted QI. At a national rate, what we're looking at is 20% in 2019, up to 22%. Now, this is, again, a macro level, provincial level results. There are probably multiple factors explaining this, one of which that I know has been suggested, and I don't have the data to share, but this is something we could certainly do, is the idea that because of the unfortunate number of deaths in long-term care, and so the increase in admissions from hospitals, with the idea that residents come from hospitals to long-term care with an antipsychotic prescription, these rates may have increased. So I would say that it's going to be important moving forward that we monitor the trends to see if they at least stabilize or perhaps even decrease. I will stop here. This was kind of a summary of our regular reporting at CIHI between your health system and quick stats. I'll also mention briefly that we do private reporting, which we call our e-reports. So facilities, regions, and ministries of health who submit data to CIHI get secure access logon to those reports. They include much more detailed information, including case mix information. And the last piece around access to data is for researchers. We do have a data request program where we make either aggregate data or record level de-identified data available to researchers to do research. And needless to say, with everything that's gone on in long-term care and COVID, there's definitely been an increased demand in CIHI's data for third-party researchers. All right, from here I'll pass it on to Mary, who's going to share some examples, some real-life examples of using CIHI data. Mary.
Thanks very much, Philippe. And I was asked if I would this afternoon share with the group just some examples about how we in our organization use this type of data for improvement work. So I do work at Pearly Health. We're a large long-term care facility located in Ottawa. And back in about 2014, we began to approach quality improvement in a much more structured and deliberate fashion, aligned with the model for improvement. And that model for improvement is centered around 3 key or fundamental questions. The first is, what are we trying to accomplish? The second, how will we know that a change has resulted in improvement? And the third question, what changes can we make that we might think would lead to improvement? And so data and access to good quality data is fundamental to quality improvement. Philippe mentioned that Your Health System, the Your Health System report, they started publishing in 2015. And looking at that data, it was clear to us that we had a number of opportunities for improvement, and that we were going to have to prioritize. And by 2016, it became abundantly clear that one of the areas that really required attention in our home was around pressure injuries. So at the time, we were reporting a little over 6% of our residents with a new or worsening pressure ulcer, which was about double the rate that we should have expected based on provincial and national reporting standards. And using Your Health System, we could see quite clearly that was, it stood out pretty significantly. We also knew, because of the thresholds that CIHI was using around determining whether or not you were within the range of standard or average or above average in this case, being poor performance, that this definitely was a problem. So the first thing that we did was get really curious about our data. So we went in and started doing some case reviews. We started looking at who else, so what areas and regions were we seeing identified as top performers, what facilities could we get in touch with. We also started looking at published best practice guidelines and comparing what we were doing here against those published BPGs. So in this case, we were using the Registered Nurses Association of Ontario. They have 2 BPGs on pressure injuries. And so we did a gap analysis against those 2 BPGs. And we identified 3 key areas where we were lacking. The first was really a knowledge issue with our nursing team. So we had a group of nurses who were incorrectly identifying and documenting pressure injuries. So looking at all types of wounds and confusing sometimes diabetic ulcers for pressure injuries. So obviously that impacts your data, but it also leads to suboptimal care and treatment of that wound. The second area we identified as being problematic was really around our use of product. And we had a lot of product, and it was really difficult for nurses to know exactly what product to use in what circumstance and situation. And then the third driver that we had identified really was just around the increasing complexity of the resident population and the individuals who lived here. So the first thing that we did is we said, first, we really needed to look at that educational and knowledge gap issue. And so we invested heavily in education for our team. We developed structured assessment tools, looked at simulation, purchase of mannequins, et cetera. And we started to see some movement in our data. So both the Your Health System data, and then Philippe also referenced some of the CCRS or e-reporting data that we were looking at as well. So the risk adjusted, and then our own internal unadjusted data. And we started to see that decline. Not quite as quickly as we'd hoped. It's a 4-quarter rolling average is how CIHI reports. And they do that to make sure you have sufficient sample size so you can have some statistical confidence. But we started to see that move. The next thing we did was really use lean principles to look at our use of supplies and how we organized product. And again, made it much easier for staff to be able to do the right thing. And then again, we started to see that data decline. The third area where we really saw some significant gains, we put aside resources and invested in a dedicated nursing role, specifically nurse specializing in skin, wound, ostomy, and continence care. And with that, we built in triggers within our electronic health record for automatic referrals and assessments, consults. She also does a lot of capacity building with the team, in addition to providing support for complex wound care. And we are now, so this work began for us in 2017. We are now reporting about a I think our last data point was 1.3% of our residents are experiencing a new or worsening pressure ulcer. And that would be compared to an Ontario provincial average at about 3.4. So through that structured approach, continuing to look at our data over time, we've been able to see some significant gains in this area. I just saw a question flash through the chat around slides. So I did not have a slide to share with you. I just wanted to share verbally. regarding our experience. But for anyone who is interested in learning a little more in detail, I'm happy to provide some background materials after the fact. And I see a question from Natalie around lean steps. So specifically, we used the principles around, for those of you familiar with Lean 5S. So this is a system around that lends itself quite nicely to supply management. So you can think about streamlining, reducing the number of options available, color coding, systems that make it really easy and organized for people to be able to grab what they need for the right situation and case. And then, did you need to do training on identifying a wound before it became a problem? Yes, so proactive. So one of the BPGs I mentioned is specifically around prevention. And so we did absolutely look at prevention. We've now fully implemented both of those best practice guidelines, but that includes everything from nutrition through to regular movement, use of pressure reducing surfaces, early signs of our personal support workers as well. So skin integrity checks, etc., before baiting. There are lots of preventative steps that are quite important. I should also just mention that this is one example, but we do find use of the Your Health System data quite helpful in identifying early on what areas we should be really curious about. So what areas do we, it's a really good, quick look to say, here's something that doesn't seem, that seems really out of bounds, or here's something where we feel that we're significantly different, and what can we learn? And it aligns quite nicely here in Ontario for those calling in from Ontario with a lot of the indicators that are identified as priorities by Health Quality Ontario and the Ministry of Long-Term Care for improvement.
Thank you, Mary, for sharing that. And I know I noticed other questions in the chat, but we'll get to those at the end of the presentation. So sort of in the interest of time, and I'll try to go through the remaining slides relatively quickly so that we have enough time to get through the questions. So next slide, please. At CIHI, we've produced a lot of COVID-19 resources that span the continuum of care. If you go on cihi.ca on the landing page, you'll see this icon, and you can sort of link on that and go through a whole ton of information. I'm just going to sort of zone in on a few use cases that are relevant to long-term care. Next slide. Before we get into the data, I do want to acknowledge that while we focus at CIHI on numbers in our work, these statistics represent people who have been impacted by COVID-19, and that is not lost on myself or anyone who works with these numbers. So this data here is an analysis that you'll find on our website, but it basically uses data from the National Institute of Aging COVID-19 tracker that tracks COVID-19 cases and deaths in long-term care, and also contrasts it with COVID-19 cases and deaths in the community from PHAC. This slide looks at deaths, and as we all know, residents in long-term care were disproportionately impacted by COVID-19 deaths. To give you an idea, during this study period, long-term care residents accounted for 3% of all COVID-19 cases, yet 43% of COVID-19 deaths. Now, the good news was that once we started providing vaccination, I think this data speaks volumes. We see that, between January and March, the first dose of vaccination were given in long-term care. You see that significant drop in deaths in long-term care. Next slide, please. This is looking at it slightly differently. It's looking at excess mortality for all-cause mortality. So it's not just focusing on COVID-19 deaths. We did this using CCRS data. It is reflective only of Newfoundland, Ontario, Manitoba, Alberta, and British Columbia, because that's the provinces for which we had data for the 6 years of data. So what this looks at is the deaths in purple or pink during the COVID year versus the 5-year average before. And we see significant excess deaths during the first wave, some as well during the second wave. And interestingly, in the third wave, that's when we gave the vaccination, there's actually fewer deaths than expected. And we think that's for a few reasons, one of which is the deaths that happen in waves 1 and 2. Second, obviously, is vaccination. Third is also infection control. So this is just a different way of looking at the impact of COVID on long-term care deaths in particular. Next slide, please. I throw this in because I thought some of you may be interested and may not be aware. So on our website, again, if you go on the COVID resources, interventions that have been done across Canada.
Sorry, everyone. I think that we have potentially lost Phil. So maybe if Mary is still on the line and we have sound, there she is, great. Perhaps there was just a few additional questions while we try to get Phil back. Sorry, I was jotting them down, so they may be out of order, but
that's okay.
The one question was when you were speaking about the 3 questions that you try to ask yourself when you take on any quality improvement project. And so someone was asking if you could please repeat the 3 questions that you stated. So when you're looking at improving care.
Sure. So the first question is, what are we trying to accomplish, or what is it we're trying to improve? And here we want to be as specific as possible about setting an aim. So for us in this case, we were talking about pressure injuries, and we wanted to reduce our pressure injuries, specifically worsening pressure injuries, from what our current level was to setting a new target. So our initial target was to be at the provincial average was our first goal. The second question is, how will we know that a change is an improvement? And this is really around that measurement piece, around saying, for those of you who are familiar with Dr. Don Berwick, he has a saying, "Some is not a number, soon is not a time." Right. So it's not just enough to say, I want to reduce pressure injuries. We have to say by how much, by when. And then the third question, what changes can I make that will result in an improvement? This is when, and it's the third question for a reason. I think often in healthcare, we get really excited about improvement. We know that it's important. And so we want to get to it really quickly. And I think sometimes we see a really good idea that somebody has, and we think, oh, well, we're just going to go implement that. And we implement the idea or the change before we're really clear about what it is we're trying to improve and how we're going to measure it, whether or not it actually worked. And so that third question comes last. And then what you do is you test those changes, you try them out. So in our case, that first change around education and some structured assessment tools, we had a hypothesis that if we did this, we were going to see an improvement. But we were actually able to then measure that over time. So one of the nice things about using some of the data that Philippe was referencing, and specifically some of the CCRS internal data over time, is that you can track that and you can actually note, okay, this quarter we implemented our new assessment. What happened to our data next quarter and next quarter? And you can see the impact of that change. So that's the model for improvement in a 30-second or 1-minute spiel. I also saw that Tanya had put up on the chat a link to the Institute for Healthcare Improvement, and they do a much better job than I do of summarizing. I think it's a Mike Evans video that's there. That's a little cartoon drawing, and it's quite good and very accessible.
Yeah, I think you did a great job of explaining it what it is, but I did put in the link in the chat for anyone else who wants to go look at it. It is a very short video, and then there's additional resources on the IHI website as well. And so just going back to your pressure ulcer example, there was one question about a list of preventative steps would be useful to frontline staff and PSWs. So I feel that maybe someone will be reaching out, Mary, to get more information from you.
Excellent.
I am back. I am
It
so
looks
sorry.
like we have Phil back. So
and you know, it's funny, my internet is the most reliable. This never happens, and then it crashes, of course. Murphy's Law. Anyway, here I am. I'm back. I'm going to try to go through these last couple slides quickly, Tanya, because I want to make sure we make a couple minutes for the more pressing questions, if that's okay. So next slide, please. Really quickly, there's a link on the slide to this. This is analysis that CIHI did for the Ontario Long-Term Care Commission. It's fascinating in that it used data that the commission actually sent a survey to all long-term care facilities in Ontario. So this is not using CIHI data. And it's a model that looked at the risk factors for severity of outbreak. And severity of outbreak is defined as % of residents with a COVID case. And suffice to say, to be brief here, that there were, let's focus on the right side of the final model. The initial model was to reproduce some results from Nathan Stahl, so let's ignore that. The final model states that there's 4 factors that significantly impact the severity of cases. The fourth one obviously being community spread. And the first 3, the presence of a medical director less than 1 day a week, the shortage in PSWs and the usage of agency PSW staff. And I just wanted to show this analysis to draw attention to it. You can go to the URL at the bottom, and there's a lot more analysis and some really interesting data there. Now, it is only in the Ontario context, but I thought it would still be maybe interesting to everybody. Next slide, please. And so I just want to wrap up. We went through sort of the data collection, the reporting, and some of the COVID resources. I want to wrap up quickly here, next slide, on some of the priorities moving forward. So for us in terms of long-term care clinical data, next slide, please. I had mentioned earlier the new integrated inter-eye reporting system. It's built on new technology, and sort of to keep it simple, one of the nice things is it has the ability to receive near real-time data. So for facilities that are submitting directly to CIHI, we can get a lot more timely data with this new IRIS system. It's built on an LTCF assessment that's a little bit shorter. And also it adopts standards like HL7 and others that basically help with the interoperability with EHR and other things. So next slide. On the HHR front, oh, sorry, this is, yeah, one of the gaps during the pandemic that was revealed with our statistics, because we base a lot of our statistics on CCRS and IRIS, and we don't have pan-Canadian coverage. Like the fact that we didn't have basic statistics like number of beds or long-term care facilities proved challenging for the federal governments and provincial governments to plan for PPE and for vaccination, et cetera. So moving forward, what we will be working on at CIHI is really getting pan-Canadian aggregate statistics, even though they may not be collecting and submitting inter-eye assessments per se. So this is an example of that, where we showed, and you can find it on our website, where we showed the sort of the number of facilities per province, including the split between publicly owned and privately owned. Next slide, please. And finally, just to wrap up on the HHR front, a lot of really exciting work happening. My colleague is spearheading this, and there's a 5-year plan. And in particular, just to highlight, to be brief here, one of them is around getting payroll data so that we can get more specifics around hours worked, sick leave, et cetera. Of course, all this data is de-identified, but also getting some key information on PSWs as well moving forward is going to be an important piece. And the last piece is really around, as I mentioned earlier, integrating all this HHR data with this very rich clinical data so that we can start making the link between sort of the scopes of practice, models of care on sort of outcomes. So that's it. And the last piece, just before I turn it to questions, from me personally, I've seen how the long-term care sector has been impacted both through my professional work, but also my personal work. And I just wanted to extend to all of you who work in long-term care and long-term care homes, like from the bottom of my heart, a big thank you for me. You've been heroes during this pandemic. And I know how difficult, well, I don't know, but I've seen how difficult it is even from a personal perspective. So I just wanted to send out a heartfelt thank you to all of you for all the work and dedication and empathy and caring for our elders. Thanks.
Thank you so much, Phil, for that. Agree. There's been a lot of work over the past 2 years in this sector, and I don't think it's over yet. And so thank you for acknowledging the hard work of our long-term care workers across the country. We do have a lot of questions, so we only have a few minutes left, so I'll try to get through a few. And thank you also to Mary for providing that kind of real world experience of what it's like to use the CIHI data in a long-term care facility for improvement. So the first question that came on early in the presentation, Phil, so not tied to a particular slide, was how do you collect data on quality of life for residents in long-term care? What types of questions do you ask and who do you ask them to?
Yeah, that's a great question. Now, InterEye has a quality of life instrument. We do not collect that data. I know the SQLI group, they do, those facilities. We have dimensions of quality of life in the InterEye assessment, things like social interactions and things like that, and many other things. And yeah, I'll leave it at that for now.
Great. And the next question is, so going back to slide 22, where you went through My Health System, just sort of the general overview. The question was, how do we get access to the site-specific information? So I don't know if you want to give a high-level tutorial or if there's a video that would link to it.
Yeah, so if you go to yourhealthsystem.ca on the landing page, you can search for any facility in that first search bar. So you just type in the name and it'll come up.
Great. There was a question as well about the pain indicator and whether or not it was specific to pain due to COVID or just pain in general.
Pain in general.
Right.
Any pain.
And then maybe we'll squeak in a few more. For your antipsychotics data, there was a few questions. So appears use of antipsychotics increases in some provinces. Any comparison to staffing ratios or arrive factors of increasing care needs when you look at the data?
That's a great question. We have not yet taken a deep dive in this, and Tanya, I wonder through the AUA collaborative and others whether that's something we want to do going forward, understanding the patient complexities and whether, you know, there's been a lot of admissions from hospitals and whether, you know, the patient characteristics look different. So I think those are all things we need to look into.
Right. Good point. Again, for the antipsychotics indicator, potentially inappropriate use is measured against a set of data. For example, if the client does not have a diagnosis on record of a psychiatric condition and received antipsychotics, then they would be counted in the data. Is that correct? Irrespective of the rationale for receiving the medication. So I guess the question is who's in that data, who's in that indicator of potentially inappropriate use of antipsychotics?
Yeah, just 1 second here. I have the inclusion exclusion. I can't remember off the top of my head. So I'm just going to go to, what was the slide number, did you say? So
I believe it was 23 or 24.
Yeah, I got it right now. Residents who are end-stage disease are receiving hospice or palliative care, and residents who have a diagnosis of schizophrenia, Huntington's, or are experiencing hallucinations are excluded from the indicator. So those would not be in the denominator. Others would be included in the denominator.
Great, thank you. Another question, more general. So in Ontario, for one province, staff have taken the step to get vaccinated, are asking how safe is it now for staff that are not vaccinated to return to work in LTC? Fear is the morale of staff working together at different levels of protection. Science strong enough to support this change in policy. I guess going back potentially to your slide where you talked about the effects of vaccination in long-term care. And just some comments about vaccinated, unvaccinated people mixing within the facility, but I'm not sure you collect that type of data.
We don't collect that type of data. We don't have, I know that, I can't remember the exact period, but staff vaccination rates were lower than residents. We know that. And whether staff should be allowed to go into a healthcare, you know, to a long-term care home to provide care is really, that is for public health to comment on.
Correct. And last question, if we have one, potentially a few seconds, do you know which provinces and territories are looking at switching to the IIRS?
Yeah, so Saskatchewan's already made that transition from the old to the new. New Brunswick has been collecting the new standard for a while now, and Northwest Territories and Yukon are transitioning as we speak. There's other provinces that are exploring that transition as well, or in the different stages of, from a business case to project planning. Yep.
Great. So thank you so much, Phil, for taking us through this presentation. And thank you, Mary, for providing your real world experience with using the CIHI data. And thank you to everyone for joining us today for our webinar. An hour always goes by so quickly, but we really appreciate you taking the time to join us today. So just as an end, to mark your calendars, so our new virtual learning series will start, as we mentioned, in May, on May 16th, with creative staffing models in long-term care. And our final LTC Plus huddle will happen on March 24th, with Dr. Paula Rochon from Women's College Hospital on addressing prescribing cascades. And so thank you again to Phil and Mary, and thank you to everyone who joined us today.
And Tanya, I know that we're running out of time, but if people have more questions, feel free to send an email to the email I put on the deck, and we'll be happy to help.
Perfect. Thank you so much. All right, everyone. Have a great
Thank you.
afternoon.